Okay, welcome everyone. My name is Mattia Romano. I am a Gestalt psychotherapist from Italy. And today I will conduct an interview with Dr. Margherita Spagnuolo Lobb, Gestalt psychotherapist and director of the Istituto di Gestalt HCC Italy, which counts three main schools for Gestalt therapy training in Italy. And we also have Professor Thomas Fuchs, philosopher and psychiatrist, expert in clinical and psychiatric phenomenology, and he is currently professor in the University of Heidelberg in Germany. The aim of today's interview is to explore and share your views on the clinical work with contemporary patients, starting from your respective theories and models, which seem to have a lot in common. And I would like to start for the first question from the two main concepts of your approaches, which are intercorporeity and the contact boundary. Professor Fuchs, you describe intercorporeity as a pre-reflective resonance between bodies, while Margherita, you define the gestaltic concept of contact boundary as the primary site of experience and change between the organism and his environment. It seems like you both conceive the mind as an interpsychic phenomenon. So, starting from these two key aspects, my question is, how can a therapist better understand every therapeutic session as the co-creation of the encounter in the here and now? In particular, can you give us your definition of the concept of resonance?
Well, okay. The idea of co-creation of the encounters found both in Gestalt therapy, but also in activism with the concept of participatory sense making. And the main idea is that sense or the meaning of our interaction is not something that we can deliberately plan and implement, but that this meaning is kind of co-created in a way that is not fully, that cannot be fully attributed to either of the interaction partners. So maybe let's take an example. A good example is the spontaneous emergence of humor, for example. So humor often arises from an event in the interaction that hasn't been anticipated. So it's against the intentions of the partners. For example, arises through a misunderstanding or a mismatch, and suddenly a laughter ensues. This is participatory sense making. So it means that in every interaction there is something like an uncharted terrain, you could say. So a ground that both haven't anticipated, and that is temporarily and effectively spontaneously emerging. So each participant brings, of course, certain expectations to the encounter, but they may be fulfilled and they may be not fulfilled. In social interactions, there's a way in which I'm not in control of what happens. So to a certain extent, I'm I'm created myself through the interaction. So who each is within the interaction is to a certain degree a result of the interaction itself. So that would be the idea of participatory sense making. But you also asked about the concept of resonance. And the concept of resonance has maybe two main components. You could say there is a continuous coordination and coupling of the two partners. They, as we know today, also unconsciously coordinate their movements, changes in speed, intonation, movement of the body, gestures are unconsciously coordinated. So studies with psychotherapy sessions have shown that the degree of this unconscious coordination of movements and utterances is also correlated to the quality of the interaction, to the attachment between therapist and client, and even with the outcome of the therapy session. So the coordination is an important component of this resonance. But on the other hand, we also have a subjective feeling of resonance. That is what I call mutual incorporation. So the experience of reaching out to the other. My body is somehow affected by the other's body, and our body schemes reach out to the other and connect in a way that I feel the other's body within my own body. So when seeing, for example, a smile in the other, I often unconsciously mimic the smile, or I feel somehow touched by the smile also in my own bodily feelings. So the other's body somehow influences our own bodily movements and sensations. And in particular, the gaze of the other is a strong bridge of this mutual incorporation. This results in a shared bodily state, an extended bodily state in which we both are included, so to speak. And that corresponds to what Merleau-Ponty called intercorporeality, so the sphere of pre-reflective attunement of our bodies. So these are the two components of what may be called bodily resonance. So an external, also visible component of mutual coordination, and a subjective component of mutual incorporation. Maybe Margherita, you want to complement or supplement this?
Thank you. That's very interesting. I was thinking similarities and differences. First is the concept of contact boundary for Gestalt therapy.
Yeah.
And this, the sense of how we co-create an experience. This is the sense of the question: how we co-create the experience. I think one important premise that we have to do about Gestalt therapy is that the founders decided to study therapeutic relationship, not an ontological state of the individual. So they decided not to study the individual per se and the experience per se, but the experience during the contact making in the therapeutic session. So they spoke of this, or the contact boundary, like the place, let's say place, because it's not a place, where therapist and client meet, and they reach each other with their self. The self is made in contact for Gestalt therapy. It means that each person reaches the contact boundary with some previous learnings. The previous learnings are what they have learned how to be in the world via their body, and what they have learned being in the world with the definition they give of themselves. So this is what we call the id functioning, the body, and the personality functioning. And the personality functioning comes from the American pragmatism, theory. Id functioning comes from Reich and all the body therapy in Europe. So they have this background, and they see their perception is a perception above this ground, that is grounded on this ground. And they decide with their will, that is called the ego functioning, that derives from Otto Rank. So the will, with their will, their intention and intentionality, we might say, but this is very difficult to say where intentionality is, So they reach the other in a certain way. Their meeting takes a certain shape that is grounded on the ground of the self, the ground experience of the self, and this created. It's new. It's created, and in a creative way, to reach the other. So all this is what you have said, Thomas. I think for me, and it's compatible, absolutely compatible with this idea of a self that is made in contact and is continuously. It's a process. It's not an instance, and it's continuously shaped by the other. The self is continuously shaped by the other. And there is a mutual interaction. And about resonance, of course, you said it very well. There are two aspects of resonance, and of course, I agree. And I could say that for me, resonance is how I'm impacted by the other. How I am impacted by the other. So in this moment, I see your eyes, and I see they're good, open, and I can breathe, because your eyes are good, and then give me the impact I have of your eyes on my perception is that I feel I can breathe. So where does this come from? And now you are pleased, maybe, of what I'm saying. So where does this come from, and how it is can be included in the therapeutic praxis or theory, in the theory of therapy? So resonance has to do with many things. I have grounded my concept of aesthetic relational knowing on the resonance, but maybe I will say something later. There's another question about this, but I think that resonance has much to do with what we co-create together. Maybe the humor, as you said, that can be.
Yes, I completely agree. There's resonance means that I'm impacted by the other, but in a way that I'm rather feel that than I know. Knowing to be impacted is rather related to the impact of his or her words, which I understand, which make me think about myself. So, of course, that is also an impact, but the impact of bodily resonance is well felt within my body without me knowing it in a conscious sense. So it's just feeling open, feeling able to breathe in the face of the other. That is something that my body does by its own accord, so to speak. So resonance is not something that we do, but that we are carried by, one could say.
Right. Yes.
Thank you very much. I'd say we are off to a great start in this context. And I would like to go on to my second question, which concerns the themes of psychopathology and temporality. A central contribution of Professor Fuchs's work concerns the lived temporality and how this is affected by the presence of a psychopathology within the patient's field. For example, the phenomenon of desynchronization found in depression. Margherita, on the other hand, often describes psychopathology as a suffering of the contact boundary and underlines the importance of giving the patient the right support to develop his or her intentionality of contact with the environment. So for the question, I'd like to ask you, from a therapeutic standpoint, how can a practitioner intervene to resynchronize the relational field when the patient has lost his or her intentionality and his or her rhythm seems unable to meet the environment's pace?
Yeah, thank you. You're referring to a concept that I developed in the analysis of depression mainly, and I developed in the dimension of social processes in which patients are embedded and from which they can be desynchronized. So the assumption is that in our social relationships, we usually synchronize our actions, our utterances, our tasks with others constantly. That is part of our social interaction, that we live in a common temporality, so to speak. But in depression, what happens is that the client and the patient increasingly lags behind, that he's not able to follow the pace of processes, that he is fixated, for example, on his past, as for example in grief and guilt, or also in trauma. And the main idea here is that therapy has the goal to re-establish synchronization through re-synchronizing interventions. For example, focusing on grief or grief work, focusing on guilt or trauma, and how it can be coped with and processed. So this would be a gradual resynchronization, rather through targeted activities that we recommend the patient. But there is also a resynchronization in terms of the micro processes, and here we come back to bodily resonance. So your question related to the relational field, where we also find a lack of synchronization in many patients, particularly in depressed patients. And here it is about the micro synchronization, so to speak. So what can we do here? Well, I think you used the term pace already in your question, and this leads us to just think of pacing as a well-known technique in therapy, and in Gestalt therapy in particular, to establish a common temporality of the session, so to speak. So pacing means to meet the client where he or she is, mirroring the client's appearance, his posture or her breathing rate, the gestures, mirroring verbally the speech velocity, the volume of the speech, the words that are used. So, paying attention to the coordination that we mentioned before, the eye contact, of course. Possibly even synchronizing breathing can be a way to gradually establish a synchrony that creates a shared atmosphere of belonging together, so to speak. So that would be the micro synchronization that we can reach, or the bodily resonance again that we can reach. So attention to these subtle processes of bodily coordination, bodily gestures, expressions, and so on, can help establish or re-establish such a interbodily synchrony.
Okay. Did you finish?
Yes.
Okay. Yeah, that's very interesting to chew. So the question is about psychopathology and temporality.
Yeah.
And the way I'm studying this is about the how the therapist can recognize the movement of the client. This is so the for me, psychopathology comes from not feeling recognized by the other in what in what I call intentionality for contact. So when a person is moving towards the other, or a child is moving towards the caregiver, and the caregiver is not sensitive to this movement, and it just goes another way or neglects the movement, then the child doesn't feel recognized, and and can withdraw, can use other ways of contact making, and or forgets also his own wishes, his own drives or movements. So in therapy, in the session, how can we resynchronize, how you say, this recognition? To mirror and to breathe as the other breathes is very important, to give basic messages to the client. Today, neuroscientists call this subcortical reactions, So if you breathe like the client breathes, and if you smile and sit comfortably, so the message, the subcortical message is, I'm here for you, and don't oppose, I'm not fighting, I welcome you, which is the basis. For me, it's the first step that the therapist does with any client, especially with traumatized clients, when this synchronization with the other has been interrupted drastically, And there is another thing that I think it's important for me, that is the need of the client is not always to be mirrored, to be seen, not to be seen, to be mirrored or to be calmed down. Sometimes the client needs to be seen in a different way, like contained somehow. And so when the client is in hyper arousal, for instance, what does the therapy do? It's not a mirroring, but it's like doing something that somehow opposes to the movement of the client, but gets the need to be contained. Even to say, now you stop and be silent. This can also be a good intervention in certain cases, because the client feels that the therapist is really interested and is able to contain his hyperarousal. Examples like this that can match the different movements and needs of the client, relational needs, the needs that are in that moment, the moment of the therapeutic session. And I have described a model that I call the dance steps model, where I consider different needs of the client, relational needs of the client in different moments of the session. Like at the beginning, the client needs to be calmed down, to be accepted in their basic ground, in their basic needs, or to create a safe ground with the therapist. So to mirror, to breathe, and to co-create a safe ground together is important. And then they see each other, they are curious to each other, then they start to do something together, to work on something together, and then they propose something new, which is the novelty of the session. And then they create a connection of what they have done with the life of the client. So this is the long story of the therapeutic session that I consider in the temporality. But temporality for me is connected with intentionality, and intentionality is a difficult concept to describe. And my question to you, Thomas, if you think that this way of understanding intentionality during the session can be acceptable for phenomenology or...
Yeah, well, of course, but we have different notions of intentionality. Going back to Husserl and Merleau-Ponty, we could say that there is an intentionality that is present on the conscious level. So that is the intentionality of my speaking right now and trying to convey a certain meaning, a certain content that I want to share with you. So that would be my conscious intentionality. But there is also a pre-reflective intentionality. That is what Merleau-Ponty called the operative intentionality of the body. So that is how we anticipate what is coming next, what we will say next, how we expect the other to react to our gaze, for example, to our smile. So the body always and continuously anticipates the next to come, so to speak, and develops its own actions and utterances and gestures according to an anticipated future. And this is another kind of intentionality, which is most important for the therapeutic process. Because here it is where the interpersonal coordination is happening. So are we in tune, so to speak, like two dancers who anticipate the next move of the other? They don't know exactly where he wants to go or where she wants to go, but they feel the movement of the other and adapt to it and go with it, are carried through it. And that is a pre-reflective intentionality that leads them through the dance, so to speak. So we have both levels of intentionality working in parallel and in interlacement all the time. That makes it a bit complicated to analyze, but I hope I think it's quite close to your concept of intentionality.
Yeah, thank you. What's the best definition of intentionality I've ever heard? Thank you. Very clear. Yeah, I feel very close to that. Yeah.
Yeah, thank you.
The pre-reflective. Okay.
Thank you. Indeed, I was thinking that was very, very clear and enlightening in some ways. And I think we can bring our dance on to the third question, where I'm focusing on the themes of intentionality, again, of the encounter, and the therapist intuition. As we already said, of course, contemporary Gestalt therapy focuses heavily on the intentionality of reaching out to the other. And Professor Fuchs also argues that subjectivity is intrinsically open to the other as a being towards others. This seems to align with the Gestalt idea that there is no isolated individual, only an organism in its environment. So my question for you is, in your views, what role does the therapist intuition play in this process of mutual recognition?
Well, the intuition, I would say, is the holistic sensing of the relational field. So precisely what you call the organism in its environment is now the two organisms in their shared environment, and this is the relational field. We cannot be explicitly aware, and we cannot pay explicit attention to all components of this relational field. That is why we need an intuition, because intuition is the holistic perception of the field and its dynamics and its atmosphere, which is a kind of integration of all what happens in this field, the expressions, the gestures, the distance between us, the tone of voices, the postures. All this flows together, so to speak, or is integrated in the intuitional perception of the relational field. And for therapy and psychopathology, it's particularly important that many components of the patient's condition, such as mood, anxiety, his arousal, his affective tension, all this is primarily perceived in the relational field through an intuitive perception. And many disorders even can be recognized or sensed, so to speak, in an atmospheric way. even before we make an attempt to make an analytic, explicit diagnosis. And this is also important for the ongoing process of dealing with the patient's problems and disorder, to have this intuitive feeling of the relational field and its particular, well, also distortion, which it can have in many psychopathologies. Think of what can be diagnostically relevant in depression and or in schizophrenia. It is precisely the mismatch, so to speak, between the expected expression or the expected relational dynamics and the lagging behind or the lack of resonance that we experience in the depressed patient. Or think of the experienced alienation that you feel in contact with a patient with schizophrenia, which has often been described in psychopathology by the term precox feeling. So a feeling of the particular atmosphere and estrangement that characterizes interaction with a schizophrenia patient. So it might be the case that precisely the disturbance or alienation of this interbodily resonance lets us feel a certain gestalt, a certain type of interaction, which is typical for a certain diagnosis. So you see that the therapist's intuition plays a crucial role for even the first steps of interaction and the resulting diagnostic intuition, diagnostic assumption that results from it. But then, of course, intuition goes on to play a role in accompanying the next steps of the interaction with a close attention and experiencing the patient's difficulties to express himself or herself, the patient's shame to fully open up to the interaction, and so on. So all this is an intuitive perception, and it plays a crucial role for the patient's feeling of being recognized, of being felt by the therapist. You understand what I mean?
Mm-hmm. Yes. Right. Can I go?
Yeah, you can just add.
I completely agree what you
with
were
it.
saying. Completely agree that the intuition of you could say the field intuition or phenomenological intuition of the therapist is the tool to give the client the sense of being recognized into a deeper experience, or pre-reflective or subcortical, how we want to say. And so I completely agree with what you have said. And the therapist intuition is a basic tool to create this understanding, mutual understanding, and going the one towards the other. I would like to add something. I start from the idea that every experience is built in between, is built with someone else. So in the experience of the person, there is something that is embedded, and is the other. The other is part of the experience of the person. And when the therapist brings us some important feeling or important experience, the way they tell us this experience creates a field where we are part of. And so we can immerse ourselves in this field where the other is present. And we can even perceive not only the feeling of the client, but also what the meaningful other has experienced, or what the environment, the feeling of the environment, let's say. So it's what the client expects from us, unconsciously expects from us. So when a client, for instance, cries, telling us an important experience, and at the same time he looks at us and flashes, what is the impact on ourselves? Now, what do we feel? And we feel that maybe the client, we are part of his environment, and maybe the client expects from us some judgment or some humiliation, something that, and he flashes because he's not self-regulated with his feeling, with his with his feeling, you know. So this is just one of the many examples when what I call the aesthetic relational knowing. So the knowing via an aesthetic, a relational knowing via our aesthetic understanding, aesthetic tools. So via our senses, we can feel not only what the client feels, but also what the meaningful other has experienced in the moment when the experience has been co-created, or the way the client has elaborated that experience, expecting something from the environment. And that in my research, this construct of aesthetic relational knowing is made of 3 factors. That's the bodily awareness, the resonance, and empathy. And we see how we have also seen or how these competences are learned in the training, during the training. It seems that empathy is not very much influenced by the training, because empathy is something that the students probably already have to decide to become psychotherapists. But resonance and bodily awareness is something that they do learn a lot, you know.
Maybe I would just like to add that your notion of aesthetic relational knowing, of course, reminds me of Daniel Stern's implicit relational knowing, and this points to the fact that our aesthetic relational knowing is something that we have acquired, and the most important ground for this knowing is, of course, laid in early childhood, where we acquire a certain intercorporal or interbodily memory of how to interact with others and how it feels to interact with the mother or the father, and how we are embedded in a shared atmosphere of the interaction. Now, this is kind of extracted in our body memories and accompanies us throughout life as an implicit relational knowing, how it feels, or how it should feel, or how it can feel to interact with others. Now, in therapy, this relational knowing is experienced anew, and it can be trained, of course, in psychotherapeutic training, because it's always something sedimented in our body memory. So it can also be changed in our interbodily memory. How does it usually feel if I interact with a depressed patient? That is something that I've learned when I started my psychiatric career, so to speak. Over time, my body extracted the typical schemes of interaction, the typical expression that made me recognize the patient's condition. And in a similar way, psychotherapeutic training can help us refine and develop our interbodily memory, so as to be able to better feel to increase our intention, to better feel the subtleties of the interaction. I think that is one of the most important goals of a psychotherapeutic training, to increase the sensitivity, so to speak.
Yeah, interbodily memory.
Yes.
Yeah, the expression, aesthetic relation knowing comes from Daniel Stern, with whom we were in contact for 9 years. We cooperated for 9 years. So the difference is that, as you know, the implicit relation knowing for him is opposite to the explicit relation knowing, that is the verbal aspect.
Yes.
That was also criticism to psychoanalysis. And I wanted to underline the aesthetic aspect of Gestalt therapy. Yes.
Absolutely. Yeah, absolutely fine with me. I understand, yes.
Thank you very much. I think you largely anticipated a little bit my fourth and last question for you, which indeed concerns the field perspective, but also the diagnosis process. We already said that Gestalt therapy, contemporary Gestalt therapy, concedes the diagnosis as often as a field diagnosis. And also Professor Fuchs has described this concept of phenomenal field and the life space, which have implications on the therapeutic work too. So my question for you is, how can this field perspective support clinicians in moving from a descriptive diagnosis, for example, the DSM, toward a phenomenological understanding of the suffering that emerges between the therapist and the patient? In particular, I would like to know from you, how can the field sentiment perceived by the trained therapist, as we were saying, shall be shared with the patient to help him or her understand his or her situation?
Yeah. Now, maybe it's also a more fundamental question about the field as being the carrier of psychopathology, so that we, both in phenomenology and in Gestalt therapy, we try to overcome the individualistic approach to psychopathology. That is, of course, the classical approach, and try to see psychological disturbances or psychological suffering as being taking place within a phenomenal field or psychopathological field, you could say, where the field is characterized by a tendency to enact certain patterns of stressful, painful, maybe impaired interactions and patterns of relationships. So this dynamics of the field creates a relational or requires a relational psychopathology that is not restricted to the individual. So that is the idea of psychopathology extending kind of beyond the enclosed patient and being a characteristic, a property of the field that the patient and others are embedded in, are acting in. And now it's quite important that a crucial part of this field escapes the patient's awareness, remains unconscious in the to use the classical term. But from a phenomenological point, this unconscious is not so much a hidden intrapsychic entity that is somehow located within the psyche in a kind of deep depth of the psyche. So in a vertical dimension, so to speak, that would be the classic idea of the unconscious. Now, this unconscious of which I'm speaking now is rather manifested in the horizontal dimension, so within the phenomenal field. Now, what does that mean? Well, the unconscious patterns of relationship and of interaction that the patient or the client brings into the field manifest themselves less in an obvious behavior than in a kind of, well, a hidden behavior, a hidden side of the patient's behavior. So to take the example of a patient who shows a kind of a kind of artificial smile, for example. He tries to smile to a certain situation, and we have the feeling of a certain mismatch between the smile and what he probably feels. Then we can intuitively sense the unconscious fear of the patient which leads him to avoid a certain interpersonal situation, maybe a situation of shame, and he tries to conceal this emerging shame through an artificial smile. And this is, of course, something we can perceive with a certain trained intuition. And we should then see the behavior of the patient as pointing to some reverse side of his expression. So this is a sensitivity to the phenomenal field, which leads us to explore the situation in more carefully, in more detail, and address the smile of the patient and how we feel like in the face of it. But I think this sensitivity, and the second part of your question, how can the patient participate in this sensitivity for the phenomenal field? Well, I think we can help patients to acquire this sensitivity themselves. So a crucial skill that they can learn is to notice the subtle bodily sensations that point to a certain uneasiness, to a certain irritation, and try to pay attention to these bodily sensations. So express them, try to verbalize them, find a kind of metaphor for it, for example, and gradually leading the patient to more sensitivity, to more implicit knowledge, so to speak, of their own reactions. Over time, according to my experience, over time, patients can develop such an increased sensitivity towards their own bodily sensations and reactions. And that would be, of course, a part of their unconscious in the horizontal dimension of the interaction, which is not accessible, or which is not necessarily only accessible to deep interpretation or psychoanalytic analysis, but it is open to a more subtle feeling, an improved feeling for one's own bodily reactions, which have to be verbalized then afterwards. So that would be my first attempt, at least, to answer your question. How should we help patients participate in this intuition?
Beautiful, beautiful examples of how we are in the situation, how therapist and client are in the situation, how the psychopathology should be seen from this being in the situation to people who are in the situation, instead of describing dimensions or behaviors from the outside.
Yes, that would be the main goal of a relational psychopathology, which doesn't mean, of course, to avoid another misunderstanding, that psychopathology can be kind of dissolved into the field. So there is nothing the patient brings into the field because psychopathology is just the depressive field, for example, or the paranoid field or the anxiety field. Of course,
Right.
the patient has a certain disposition to feel this anxiety or this depressive mood in a given situation, and this disposition is actualized, is realized now in the
Right.
current field. But that doesn't mean that the field is the only carrier of psychopathology.
Right. And now to me, it brings the question of how to teach psychopathology, because the manuals are have also the aim of teaching or creating some order in the healthy disorder of life, let's say, no? So
Yeah.
we don't want to create a manual that is external to the relationship. And this is quite difficult, I think. So,
Yeah.
for instance, what the example that you were doing of the client that smiles in with a mismatch, like he smiles and this is out of the context.
Yes. Yeah.
What do we do? Because we know that smile, we feel that smile is a way of defending themselves from an unpleasant feeling. So what do we do as therapists in front of this mismatch of the client? So this would be a good teaching, for our students.
Yes, absolutely. Well, because usually one could say, or one would assume that we unconsciously, again, feel that there is something painful for the patient, and we unconsciously avoid it, or we don't want to hurt the patient, and then we avoid it. And it is well known that particular in patients with anxiety disorders, for example, it's not recommendable to avoid all kinds of possible confrontations or avoid uh, um, mm, difficult situations, because that is not helpful for the patient.
No, they need to be contained,
Yeah,
instead
yeah,
of, yeah.
yeah.
For me, I think I go back to the concept of contact boundary,
Yes.
because I think that a good way to teach very roughly the differences between among our clients can be how we perceive the contact boundary with each client. So there is if a client has clear contact boundary, so he knows he knows about a feeling, if a feeling belongs to him or to the therapist, he has good boundaries. Now he knows that if he's fearful, he is fearful and not the other. So this could be a line to say there's a neurotic client, he knows what is his own and what is the other. And if the client, it doesn't have a clear contact boundary, like he is fearful, but he thinks that you are fearful, no?
Yeah, yeah.
Then this could be an approach to psychosis. Maybe there is no contact boundary at all. It's not possible.
Or at least something like a projective identification, as in borderline patients. So there is a
Yeah,
kind of
the other,
merging
right,
between my own feelings and those that I perceive
right.
in the other.
Yes, and the other possibility is the contact boundary being unclear, unsure, and undefined, like in borderline clients. It's ambivalent.
Yeah.
Uh,
Yes. Yeah.
am I good or am I bad with my therapist? Do I love him or I want to kill him? Something like that. And then there is the traumatized contact boundary, which is different.
Yeah.
It's
Yeah.
even different because the ground experience has collapsed. And so the way they make a contact boundary is it's even different. But I think we have finished our time, so we don't have to, we cannot continue with this. But what you say about the diagnosis and psychopathology is very strong, and it supports me to go on with this idea of teaching what happens between therapist and client instead of what happens just to the client,
Yeah.
So thank you.
You're welcome, Margherita. It was a very stimulating conversation. Thank you so much.
Okay.
Thank you very much. It was very interesting, and pleasant to hear your very deeply humanistic take on psychotherapy. And I want to thank everyone who will listen to this interview, and we hope that everyone will find some novelties or some curiosities to bring into their clinical work with their clients, to see them as the human beings that they are.
Okay.
Thank you very much.
Thank you, Mattia.
Thank you,
very
Mattia.
much, Mattia. Thank you.
Thank you.
Okay.